I think we can move on to our next speaker now. So the next topic which we are going to discuss today is common pitfalls in interpreting thyroid function tests. So TFTs, I think even patients are themselves getting it done and coming to us with various reports. So it is a very common problem which we see in our OPDs. So I think Dr. C M Batra is going to discuss regarding that. He is an endocrinologist in Sarita Vihar, Delhi, and enormous experience, 42 years of experience sir has. So over to you, sir, please.
Good afternoon, friends, and thank you, chairpersons, for the introduction. I'm going to talk today in the next 20 minutes about pitfalls in the interpretation of thyroid function tests. So before we go to the pitfalls, we have to recapitulate our normal physiology. That is, the hypothalamus produces TRH, which stimulates the pituitary to produce TSH. TSH stimulates the thyroid gland to produce T3 and T4. And once T3 and T4 has gone into the bloodstream to reach the target organ, target cell, it has to go to the cytosol and needs transmembrane transporters. It can't go itself, it has to need transmembrane transporters, of which the most common is monocarboxylate T8, which is necessary. And then after it has gone into the cytosol, then it is deiodinases act on it to convert T4 to T3 and T4 to reverse T3, and then both T3 and reverse T3 to T2. So this is the normal metabolism. Now T3 is absolutely essential to convert T4 to T3 because only T3 can go into the nucleus and act on the thyroid receptors. So once it acts on the thyroid receptors, this happens. Like we have now, this is a diagrammatic representation of the thyroid receptor. Now it is in conjunction with the retinoid X receptor, and when in the absence of T3, there's a co-repressors which are recruited which prevent the action on the gene. But when the T3 comes in contact with the thyroid receptor, there is co-activators recruited and gene transcription takes place. So what happens when there are mutant receptors? When you see the wild receptors, normal person, T3 acts on the thyroid receptor, repressors are removed, co-activators are activated, and action takes place. But in the mutant receptor, this does not happen. Now, once you have these thyroid function tests, all of us know that in the normal person, T4 will be normal, TSH will be normal. In a thyrotoxic person, T4 and T3 will be increased, TSH will be decreased. In a hypothyroid person, T4 and T4 will be decreased and TSH will be decreased. Till this time, there is no problem at all. Thyroid function interpretation is the easiest thing in the world. But now the problems start when these things happen. The next scenario is that you have T4 and T3 which is normal, but TSH which is decreased. And the causes of this are subclinical hyperthyroidism, recent treatment for hyperthyroidism, drugs like steroid and dopamine which decrease the sensitivity of the TSH to the TSH receptor, and the non-thyroidal illness. The next set of these set of thyroid functions which can be there is the T4 and T3 are decreased and the TSH is also decreased. Then you have to think of central hypothyroidism and isolated TSH deficiency and non-thyroidal illness. The other set that you can get is last set, which is most important, is free T4 and free T3 will be increased and TSH also is increased. This you have to think of assay interference, familial dysalbuminic hyperthyroxemia, thyroxine replacement therapy including poor compliance, drugs like amiodarone, heparin, non-thyroidal illness, neonatal period in which there are bursts of increase in the TSH and T3 and T4, and resistant to thyroid hormone, and lastly disorders of hormone transport and metabolism. Now, how do you approach such a subject? So, when you see a patient and you get the thyroid function test, and the thyroid function test appear weird, the patient's clinical picture tells you something else, and the thyroid functions tell you something else. Then what do? You reevaluate the clinical history. Think of the age of the patient. It's well known that in elderly, the TSH up to 7 to 8 is normal. After 70 years, 7 to 8 of TSH is normal. Neonatal period also, I've told you get bursts of T3 and T4 and TSH, so T3, T4 may be increased and TSH may be decreased. So thyroxine, then you have to think of pregnancy and its changes. We all know that in the first trimester of pregnancy, during pregnancy, the HCG levels are going to increase TSH in the first trimester, and even free T4 and free T3 are also increased from second trimester. And so we have to use pregnancy reference ranges and trimester-wise reference ranges. Then if the patient is on thyroxine therapy, you have to consider confounding dietary factors or medications, malabsorption syndromes, altered thyroid hormone metabolism, non-compliance. And this is very important. You have to consider the drugs that the patient is taking, because amiodarone can cause weird thyroid functions. Furosemide, heparin, corticosteroids, and dopamine, they can all change the thyroid functions. So if the patient on this drug, consider that as a cause. And lastly, the patient is sick, patient is having the stress, have undergone surgery, think of non-thyroidal illness. Then at this point of time, you have to reassess clinically your thyroid status, the physical and the history. Ask the patient if he has other autoimmune disorders, if he has received some vaccination recently. If the patient, then clinically assess whether the patient has a goiter, whether he has tremors, whether he has eye signs, whether he has dry skin. See that the patient is hypothyroid, euthyroid, and hyperthyroid. Make that up in your mind, and then decide which thyroid function test is most likely to be discordant. And then you have to exclude thyroid hormone or TSA, SA interference, and investigate for, then finally, if that is also not there, investigate for rare genetic causes and hypothyroid function. So let's first come to what is very important, is that there are 6 primary types of interference to the main sites affected in both the assays for TSH and for thyroid hormones. And this is important because 1% of your, it is estimated that 1% of thyroid function test you do have assay interference, which is a large number considering the thyroid function tests which are done daily. And basically, if you come to this TSH assay, it's a sandwich assay in which there is streptovidin weeds to which the sample is attached. Then there are two antibodies. There's a bialinated capture antibody, there's a detection antibody, and then you put the serum analyte into it. So, and then when you put the serum analyte, the TSH is captured by the 2 antibodies, and then this signal goes to the ruthenium. Ruthenium gives you a electrochemiluminescence, which you detect as TSH. Now, what can go wrong? First, there may be particles called macro TSH. You heard of macroprolactinemia? Same thing is macro TSH, which are which are the TSH which is combined with anti-TSH antibodies, which form large molecules. These large molecules are not easily filtered by the kidney, so they collect in the body. So they give you a false TSH rise. The next can be, the thing that can be wrong is that can be anti-streptovidin antibodies, and they can be biotin. There is a common substitute which is being used these days in vitamins, in a lot of food supplements, and biotin excess can also play havoc with your assay. Then you have heterophil antibodies which are present, which also can bind to these capture antibodies and produce wrong TSH assays. Then you have anti-ruthenium antibodies, which can also do the same thing. Coming down to the thyroid hormone assays, which are basically competitive assays, again you have streptovidin magnetic beads are there. Then you have a capture antibody, which is bioinated, then which to serum analyte is added, and along with the serum analyte, there is actually tagged thyroid hormones also added. So there is a competition between the tagged thyroid hormones and the thyroid hormones in your sample, and based on this assay works, and the ruthenium signal is captured and that gives you the thyroid hormone values. Now, what can go wrong? Anti-streptovidin antibodies can go wrong. Biotin intake can cause problems. Then you have anti-thyroid antibodies, that besides thyroid antibodies to anti-TPO, you already know, you can have antibodies to T3 and T4. They can also play havoc with your assay, and anti-ruthenium antibodies. Now, these are the various assays. What do these antibodies do? Like TSH is bound by both capture. We know that TSH I have already told you about, but look at this P. Look at this. Now there is what is called as cross-linking antibodies. There is a human anti-animal antibodies or heterophilic antibodies, which cross-link the capture and the detection antibodies, and thereby produce false TSH increase. Or you can have antibodies causing negative interference. These antibodies, they combine the capture and detection antibodies. They can join either with the capture or detection antibodies and cause interference. So what do you do with this interference? When you have a TSH which is decreased, which is high, and the T4 which is normal or increased, think of macro TSH or ruthenium antibodies, and the way out is PEG precipitation, polyethylene glycol precipitation or chromatography. And heterophils, you think of blocking agents. For thyroid hormone antibodies, the method out is method comparison. You use different antibodies for the assay, or PEG precipitation, or thyroid binding defects. You can use ultrafiltration and equilibrium analysis, or genetic analysis. And if the patient is taking biotin, you use assays where they don't use biotin. So, to summarize the assay interference business, you take a good history and physical examination, repeat the analysis with the same method, because sometimes wrong pipetting and wrong errors can occur in the lab. Then repeat the analysis with another assay method which does not use the same antibodies. Then another method is that you take the sample and you do serial dilution of the sample and checking for linearity, and do PEG precipitation and blocking agents and ultrafiltration, ultra-equilibrium dialysis. These are the various methods. Now, this assay interference is not something hypothetical. It can cause problems. Like what can be the problems? It can cause problems in wrongly giving the patient thyroxine, wrongly using thyroid scans, increase in the thyroxine dose, increase in the anti-thyroid drug use, decrease in the anti-thyroid drug use, and delay in the anti-atenolol administration, delay of the thyroid diagnosis. So it's important. The next thing you have to think about is what drugs the patient is taking, because the drugs can also interfere with the thyroid assays. Now central thyroid TSH inhibition can be caused by dopamine and dopamine agonists, somatostatin analogs, rexinoids, anti-epileptic drugs, metformin. Absorption problems can be caused by biliary acid, bile acid sequestrants, ferrous sulfate, calcium carbonate, eloxifene, proton pump inhibitors, or listat. And of course, the secretion of T3 and T4 can be altered by thianoids, that's anti-thyroid drugs, and ionic inhibitors like perchlorate, thiocyanate, nitrate. And this is very important. These drugs are very commonly used: NSAIDs, diuretics, free fatty acids, heparin, and these can cause problems in the transport. They can displace the thyroid hormones from the bound form into the free form, cause increase in the FT3 and FT4. And metabolism, the inducers of P450 and the 5-DI inhibitors, these are all important. So lithium is a very common drug causing problems. It can cause overt or subclinical hypothyroidism. It can cause thyroiditis. Tyrosine kinase inhibitors can cause primary hypothyroidism. Then immune modulators can cause Graves' disease, especially the one receiving or drug against multiple sclerosis, heart for HIV therapy, and INF alpha for chronic hepatitis C. And Hashimoto's thyroiditis can complicate INF alpha therapy. Amiodarone is a very common drug used for a very common drug used in cardiology for very common drug used in cardiology, and it contains a very high amount of dietary iodine, which is highly lipophilic, and it can cause transient increase in the T3 and TSH and T4. It can, with the normal FT3, it can cause two main types of thyrotoxicosis. Type 1, which is large iodine load precipitating latent thyroid autonomy, and type 2, destructive thyroiditis, and inhibits T4 to T3 conversion, so that T4 is markedly more than the T3. And increased TSH and decreased T4 hypothyroidism can also occur in 15% of the patients. So amiodarone is a very important drug history to take. Now, the next thing I'll be switching on to is that can cause problems is peripheral thyroid, the changes in the central and peripheral thyroid axis in acute versus prolonged critical illness. So when you go to the ICU and see patients with critical illness who have weird thyroid function tests, think of this disease. That is, think of acute prolonged critical illness causing thyroid disease, non-thyroidal illness. So in the acute phase, what happens that there is the acute phase of the illness, the TSH increases, and the T4 can increase, T3 becomes low, reverse T3 increases, T1 decreases, T3 increases. Whereas in the chronic phase, what happens is that the hypothalamic expression decreases, the TSH decreases, T4 decreases, T3 decreases, and on the reverse T3 increases, and D1 decreases. So these are changes that occur in acute thyroidal illness that can confound your thyroid function tests. And this is what happens in the case of critical illness. Initially, what happens is the cortisol is always high in critical illness because of stress factor. The anti-pituitary hormones, that is the TSH, goes high in the acute phase, then comes down. The target organs, the T3, T4, they all can come down initially, and they remain down throughout the illness till the recovery phase. Recovery phase, you have a spurt of TSH, and the T3, T4, and TSH, and even the cortisol normalizes then finally. So what do you do? How do you make a diagnosis of hypothyroidism in non-thyroidal illness syndrome? It's a very difficult diagnosis. In hypothyroid patients, serum TSH may decrease to normal range. History of previous thyroid disease and treatment is important. Examination of skin changes, goiter, high serum TSH and low T4 also found in patients recovering from non-thyroidal illness. Keep that in mind. And if you get a low serum T3 and T4 ratio and low reverse T3, then you think of hypothyroidism, because in critical illness, what happens is that the T3 is low, T4 is higher, and reverse T3 is high. So that is a very good test to rule out the difference. The signs of hypogonadism, hypocortisolism, MRI cell showing empty cellular and pituitary tumor help in diagnosing secondary hypothyroidism. So how do you make a diagnosis of thyrotoxicosis and non-thyroidal illness? The clinical signs of thyrotoxicosis like tremors, eye sign, goiter, thyroid antibodies all help. Low serum TSH, high serum T4 may occur in early stages of non-thyroidal illness syndrome. So think of that. Sometimes diagnosis is not possible, so TFT is repeated after recovery of the patient. And combination of thyrotoxicosis and non-thyroidal illness causes T4 thyrotoxicosis, in which the T4 is high, T3 is normal, and the TSH is low. So this is the A logarithm how you proceed. When you have elevated free T4 and T3 with non-suppressed TSH, you confirm elevated free T4 by equilibrium analysis or two-step method and exclude SA disturbances, exclude confounding drug therapy or intercurrent illness. Then you check whether they are effective relatives. And then there are two conditions which are left which have to differentiate it. That is TSH secreting pituitary adenoma, which is pituitary adenoma secreting TSH, thereby causing thyrotoxicosis, and resistance to thyroid hormone syndrome. So you check the affected relatives. They won't be affected in TSH adenoma, but will be affected in resistance to thyroid hormones. And Alpha subunit will be elevated and to TSH ratio elevated and TSH secreting pituitary adenoma. TRH response and T3 suppression will not be there in TSH secreting adenoma, and TRH RB gene analysis will be normal in TSH secreting adenoma, whereas there will be mutation 90% of the patients with resistance to a thyroid hormone. So the genetic disorders come, the causing discordant thyroid function come last, and this is the gene that is the albumin gene, we think, which causes familial dysalbumic hyperthyroxanemia. Then there is the resistance to the thyroid hormone, which causes resistance to thyroid hormone beta, and then the what is called as monocarboxylate T8 or Allen-Hedden-Dudley syndrome, and there's protein deficiency. All these cause disturbances in the T3, T4, TSH. And this, it's very simple. The only thing that is raised is free T4, rest everything is normal. And then when you do the genetic analysis, you find the albumin gene mutation. Here, or you can do equilibrium dialysis, and that will give you an answer. In this resistance to RTH, the causes raised T3, T4, normal TSH, and raised reverse T3, normal sex hormone binding globulin. There is goiter present, selective hypothyroidism is present, and Allen-Dudley syndrome, there will be normal T4, raised free T3, and TSH will be normal, reverse T3 will be low, mental and psychomotor retardation is there, and selenoprotein deficiency, there will be raised normal free T4, raised free T4, normal free T3, there will be TSH will be normal, there will be growth retardation, male infertility, skeletal myopathy, hearing loss. So, summarize, knowledge of hypothalamic pituitary thyroid axis physiology is central to establishing the correct diagnosis, where clinical features and TFT results appear discordant and incongruous. Reappraisal of the clinical context is necessary. Take a comprehensive history, including family history of thyroid disorders, drug history, history of other diseases the patient is suffering, symptoms of hypothyroidism and thyrotoxicosis. Complete physical examination for goiter, hypothyroidism, thyrotoxicosis. Establish a clinical diagnosis whether the patient is suffering from primary or secondary hypothyroidism or thyrotoxicosis or a euthyroid state. Establish whether the laboratory findings correlate with your clinical findings. Rule out non-thyroidal illness, rule out drug effects, targeted investigation to definitely exclude assay interference. Then finally think of genetic and acquired disorders, and which are very rare. And finally, this is a book we have written, and anybody who wants a copy of this can write to us, and we'll be happy to provide them a copy. It's available on Amazon also. Thank you.
Very elaborative presentation, sir. Thank you so much. The board is open for the questions. Anyone who wants to ask something?
When we are using amiodarone, how frequently should we check the thyroid functions?
That's an important question, because it is possible that initially it may not cause, but during the therapy of amiodarone, maybe even after 2-3 months, it can certainly cause hypothyroidism or thyrotoxicosis. So first of all, you have to keep a close watch on the clinical picture, and then maybe initially 1 month after starting amiodarone, or before starting amiodarone, 1 month after starting amiodarone, and maybe every 3 months.